Hello everyone, welcome back, and this is GH. My name is Anita, and we're gonna be talking about postpartum hemorrhage. If you've been watching my previous videos, we've been doing so much under the new NMC. We've been talking about CBT, we've been talking about Osce under the midwifery. We haven't been talking about the nursing, all right, but I know there are so many videos under nursing, but just a little under midwifery and a little under mental health. I'm trying as much as possible to cover these areas for you as well. Stay tuned. And I hope you enjoy the section under the postpartum hemorrhage. Welcome back. So as I mentioned, today we are going to be talking about the postpartum hemorrhage, and the first point you need to know, as I mentioned in my shoulder distortion video, I said recognize the need. That's your ability to recognize that this is an emergency situation. You're going to need help. You're going to pull an emergency buzzer. These three important notices need to be verbalized. Other than that, it's a total film. So you recognize that, oh, that is a PPH. I'm going to pull the emergency buzzer just to get people to come in to help me and assist me manage this situation. And when you pull the buzzer and you request a PPH, and you also need to also verbalize that PPH is caused by four things, and that is the tone, the tear, the trauma, and the thrombin. So your ability to recognize these four things, and also you're going to need an obstetric. This time you don't need a pediatrician because this is a blood and obstetric emergency. So you are going to need more of the obstetric team, the anesthetist, the senior midwife, the scribe, but not a pediatrician. Hope you get that in mind. The second point is going to be support the woman to lie back and commence oxygen therapy. So giving oxygen under high flow, and it should be using every breather max. So you give the woman oxygen because sometimes when you are losing so much blood, the same blood is what carry oxygen circulating to our body. So you need to support the woman to help her breathe. So your first point, when you are intervening a PPH, you support the woman to lie back, then you give high flow oxygen. The third point is you need to rub up a contraction, a uterine contraction. So you need to demonstrate this action on the dummy. So you show the woman you show the examiner how to perform like massaging the fundus or massaging the uterus to stimulate contraction. So if it's caused by a tone, that is, there is a toning of the uterus, then you need to massage the fundus to make it firm. Sometimes stimulating the uterus can stimulate contractions and make it super firm, and that can help to control the bleeding. Remember, the bleeding is coming from a placental side, so the more we try to constrict the muscles around the uterus, the chances of you reducing blood flow out from the placental side is high. The fourth point is you need to give 2 cannulations. In some advanced technology or some advanced healthcare system, sometimes some people go for just 1 cannulation with 2 connectors and starts with Hartmann flow. Yes, but for the sake of the examination, as it is stated in the mock or the marking criteria, you need to give 2 large balls cannulation. So that is, you can cannulate here and you can cannulate there. However, it's your ability to identify veins. So that may not say that you necessarily need to cannulate these parts. You can cannulate at the brachial artery or anywhere you find a vein. So you cannulate and you start Hartmann flow, and that is intravenous fluid. Some people may call it Ringer's lactate. However, don't mention Ringer's lactate, just mention commence intravenous fluid such as Hartmann. So after you've given IV fluids, that is Hartmann, you can also give sodium chloride 0.9%. Then you can start either sodium chloride or Hartmann. The next point you need to go on to is performing observations, because you need to make sure that mother is not running into hypovolemic shock. When you perform observation, what are the signs you need to know that, oops, that is a sign of shock? So if you are having a hypotension that is systolic less than 100, or you are having a tachypnea that is excessive breathing above 30 cycles per minute, or if you are having a tachycardia that is above or if you are having tachycardia that is above 100 beats per minute, or you are doing a capillary refill and you realize that the refill is greater than 2 seconds, then you should know that your lady is showing, it depends, start to show signs of shock and needs to be intervened, because we do not want the woman to run into shock. We always need to make sure that we are intervening as quick as we can. You need to verbalize, and the next step that you need to verbalize that you are going to intervene with medication. And we've got some uterotonics that are used to intervene when you have PPH, and you can go for symptometrin, syntocinon, igometrin, carboprost, tranexamic acid, misoprostol, oxytocin infusion. Now, one of the medication, which is ergometrin, is a medication that can raise the blood pressure of the lady. So you need to be careful that the woman already does not have a high blood pressure. Some people are already having high blood pressure and deliver the baby and run into this kind. So they may already be having an extremely high blood pressure. You do not want to give an igometrin to a lady who has high blood pressure, because that medication already tends to step up the blood pressure already. So you need to verbalize it. You're going to give igometrin only if mom do not have a high blood pressure. Other than that, please stay away from this medication. There are so many other uterotonics you can use. As I mentioned earlier, when we have symptometrin, we have syntocinon, we have oxytocin infusion. Now, when I say oxytocin infusion, is giving 40 units oxytocin in normal saline, so that becomes an oxytocin infusion. Then we have misoprostol or misoprostol, as some people may mention it. We have carboprost and we have tranexamic acid. Our next point is performing a bimanual compression. This is a point that needs to be demonstrated. You need to show the examiner that you know how to do a bimanual compression. So how do you perform a bimanual compression? If the examiner does not allow you to perform a bimanual compression, then you need to verbalize how you would have done it if you had found yourself in such a similar situation. So what you do is you go in with your full hands through the woman's vagina to the uterus, create a fist. Then the other hands you will use an external pressure, so that will be on the fundus, pressing against the wall. So what you do is you are trying to trap the placental side to stop it from bleeding. So this hand goes into the vagina, it creates a fist in the vaginal wall. The other hand is on the fundus at the external abdomen. That is, this hand is not going inside, it's just going to be on the fundus. Then you press against it, trapping the uterine wall against each other to stop bleeding. If the bleeding still doesn't stop, then you need to verbalize the awareness of other interventions. And with this one, you're going to involve the anesthetist to come into play. So the anesthetist will come and give anesthesia, because there's a chances that you'll be going to theater, or you might be performing a manual removal of the placenta, or retained membranes, or retained part of the placenta. And also, there could be that there are some undiagnosed cervical tear that is causing an extreme bleeding, so that needs to be sutured. You can also consider the BLH. You can also consider the tamponade, and the BLH, the uterine, if I remember, there's the uterine balloon tamponade. Yeah, that's it, the uterine balloon tamponade, or extreme form, that is hysterectomy. When it comes to placenta site and how the placenta locates, we have ways, weird ones, that the placenta embeds in the uterine wall that do not even detach out of it. So when you are finding yourself in such a situation, then you know that there can be a chances of you undergoing a hysterectomy, because it's already in the muscles and has already extended its wings through and cannot come out. So someone wonder, why would you have to do a hysterectomy when it could be that the placenta is stuck in. When you read about placenta accreta, you know that some placentas are super weird and are stuck in the muscles, in the myometrium instead of the endometrium. And now your next step after all this has been done is you need to debrief your lady. Let her know what has happened. Although she may know that, okay lady, or okay Lily, we are going to do this on you, we are going to need you to do this for us, and be like, yes. But at the end of the day, you need to sit them down, go through everything with them, why the need of each step was needed, why you had to do this. So that is a debrief. You need to debrief your lady, let them know what happened, be honest in everything you did, what could have been done better, what could have been done differently, would it have had any effect. Just let them know. Performing a duty of candor is always important. After you've managed this bleeding, you need to perform observation, because you need to be sure that the lady is not running into shock. So you perform your observation, you document everything, then you dispose your PPs in the infectious waste and perform your hand hygiene. Once you have done all this and you are happy, you perform your hand hygiene following the WHO guideline, you've done your documentation, everything needed. Now you don't need anything. So thank you so much for watching my video under the postpartum hemorrhage, and I hope this has been super helpful to anyone who is preparing to write the exam. I know some people were supposed to have the exam, but I just couldn't have the chance to make enough videos for you all before you wrote your exam. But I hope my previous videos was super helpful to you, and I hope you guys have been able to pass your Osce. We are trying to go beyond the scope of just Osce and CBT. Very soon we'll be talking about success story. I'll be so happy to share my success story. I've been through so much, and I think now midwifery in the UK has super changed. Like, you get to, should I say, it has become super easier now to get a job in the UK as compared to the time when I was looking for a job, as when I started the process in 2018. So you can imagine I've been through a lot. I started in 2018, then I secured a job in 2022, and I got to the UK and I wrote my exam. I failed, I passed on the second attempt, and after that, trying to get my PIN was also a problem. After everything, I was in the UK in March, and I had my PIN finally in August. I got to practice, and now I'm practicing as a midwife. So it's been quite, should I say, a stressful journey. I know some of you are trying to give up in terms of financials, in terms of other stuff, but I do not want you to hesitate. You should have known the amount I had on me when I started this process, and everything I have been through trying to get there on my own. It hasn't been easy financially. Even if someone wanted to help me, it's just, that's just gonna be another story. I'm just gonna have time and explain everything to you, just for you, that you need to know that if you have aimed for something, just go for it, no matter how much is needed, or in terms of finance, in terms of physical, in terms of brain, just go for it. And once you've achieved whatever you want, you'll be sitting here with me laughing together. I hope you've enjoyed this section under the PPH as well. Please stay tuned. We will try to talk about this. I'm trying to try and cover everything. We've talked about shoulder dystocia, we've talked about PPH now, so we're going to talk about sepsis. Once you are done with sepsis, then we move on to the breech bed, then we are done with obstetric emergencies. Thank you for watching this video, and I hope it has been super helpful to you as well. Bye.